Okay, the next presenter will be the Financial Management Group by Silas Tukan.
On the 18th of August, 2017, advocacy was conducted to AG, Director of Treasury, for Central Commodity Account. Then we conducted training on financial management for transformation project by Kuni Foundation. This took place on the 29th of May to 2nd of June. We equally conducted another activity that has to do with presentation of financial management at the quarterly review meeting in May 2017. We prepared a financial operational module in June 2017. And I'll go back to that place to make some better explanation. We got approval from Ministry of Finance to centralize all the pilot for health facilities and to open a centralized account for all the 28 facilities. Then we equally do training on the 28 pilot health facilities for financial management. Another training component that took place on the 30th to 31st October 2017. Then there was preparation for draft service level agreements with Zenith Bank. This took place on the 31st October 2017. Achievement of financial team, operationalization of the central account, which all of us seated here will bear witness that most of the facilities funds were moved into the central account, and 28 sub-facility health accounts are equally open and linked to the central health commodity account, which will keep track of all the records that are coming from your facility, both financial. Then transfer of funds to the 28 health facilities. We discovered that not all facilities of the 28 health facilities, we discovered that 28 health facilities transferred their fund to obey the directives of the Honorable Commissioner, while 4 are still pending. Then we equally had an achievement on the development of the financial model, which took place in June 2017. Then deployment of Zenith Bank agents to all the health facilities for financial collections. Challenges. 3 primary health centers yet to transfer their funds to the centralized account, and 1 tertiary health institution, 1 state government secondary health institution. Then one of the other challenges we discover as a financial management team is from the inception of this project, there was no provision that was made to fund all the sub-project team for the transformation project, which constitutes a big challenge, but that did not really hinder progress. Most of the teams keep functioning based on available funds from their pockets, and it is organized projects like this one that we actually get support from the supporting partners. But in all the sub-project team, because of the benefit of this project, members were willing to work assiduously just to ensure that they meet up with their project milestone. Some health facilities were point of initials of the project, they were like preventing the bank officials to actually have access for the collections of the funds, which actually constituted a challenge for the project, and non-deployment of point of sales for cash collection services by the approved bank. Most of the financial transactions that we expect to do, if the bank equally is supposed to be doing point of sales, which will be going electronically, and everything will be stored on the cloud. So this constitutes a challenge that is still pending up to now. Then we have discovered that despite the transformation efforts that we are making, some personnel are still trying to beat the system by running parallel DRF, bringing in commodities to sell in an effort to sabotage what the states approved to handle as a state, which is a challenge. And we are advising all facilities personnel, since all the management staff are here, to give them heavy warning to desist from such practice. Then we had security threats hindering smooth access to facility sites. This constitutes another challenge too. Some of our lessons learned. The centralized account is an opportunity for pool funding and for the betterment of the citizens of Kaduna State. New skill sets, because of the new things that are coming on board for the project, new skill set ideas is being required for the management of both financial data and other related information for the system. Then we have capacity gaps affecting operation of the project, which we all agree that many of us were benefited from skills of sending SMS platform. So many are still lacking some of the basic skills in some relevant areas. So we equally learned that funding is an essential driving force to all supply chain activities. Then stock out of drugs and medical consumables can quickly equally affect the patient and the financial contributions to the project. These are the lessons learned. But because we did something that is very important and this house needs to have a better understanding of it, I want us to open up the SCTP cash flow model so that we all see what the project has for the people of Kaduna State. This is the cash flow or the financial proposal for the project. At the beginning of the project, we expect everybody to contribute 100% of cash coming into the project, 100%. And the project has designed it in such a way that 80% from the 100% will be used to procure health commodities for distribution to all participating facilities for this project. And it has set aside 20% markup that will return back for other legitimate expenses. For the supply chain, 20% will be for supply chain operations, which will include legitimate expenses. It will include all other benefits that we need to have at the facility level. And it will equally, from the 20%, it will serve all the other 10 sub-projects that are components of this project, which has to do with 3PL services, financial management services, which will include payment of banks, collection services, warehousing operations at the DMA level, value-added services, which will include packaging of materials, distribution of unified selling prices, price lists, stationaries, pens, calculators, and many others. It will equally, from the 20%, a certain markup will be given for data visibility and analytics, which we are deploying a technology called Control Tower and the SMS data platform, which was part of the first presentation we all see, and that we are sending data to We equally have coded prescription sheets, which all of us are using at the facility level. Most of these things, operations, will be coming from the 20% markup that this project has assigned. Then we'll equally have exceptional based monitoring and supervision, which will be coming still from the 20% markup. And this will include all the facilities that are coming from primary health care under one roof, tertiary and secondary health facilities from the State Ministry of Health, and the operation of the DMA itself. All these operational expenses for the project will be coming from that 20%. Then we'll equally have a percentage for health facility staff dispensing, which will equally be on a motivational level. It will be like a performance rewarding system. As long as your facility is performing or your personnel are performing, something will be going back to them. Then point-based incentive and monthly performance review, annual performance appraisal recognitions, all this will be coming up. And this design encompasses all the health sector. You can see the major key players, which are the health facility, irrespective of whether you are primary health care, secondary health care, or tertiary. As long as you are under the roof of Kaduna State, you fall under the health facilities management, the Ministry of Health itself, the Primary Health Care Development Agency, and the Drug and Medical Supply Management Agency. The only institution that is excluded from this financial flow now is the training and institutions, which has no direct role to play immediately on the project right now. But it does not mean that we'll exclude them in the future when we feel there is need for them to be part of this process. Thank you for the good listening, and I'll open up the floor for us to ask questions, if at all there is any.
There is 100% cash. Then 80% of that cash will be used to buy commodities. And in the course of your presentation, you are talking of 20% markup. Because maybe the DMA may have an operational cost, of course, which will be part of their recurrent expenditure, which they can use to do all what you have mentioned. So I don't know whether you mean the 20% of the 100% of the cash is the one to be used, or there is an additional markup from the 100% cash. That is from the commodity that is already bought, you put a markup of maybe 20%. Please, we need to have some clarity on that. Thank you.
My own is basically an observation and suggestion. I don't know if the prices of these drugs can be. I think round up, because I used to have issues between patients and the bank staff collecting cash. Just this morning before coming here, I had an issue whereby a patient was asked to go and pay about 468 naira. Now, I'm going to the bank to 400. That 2 naira created conflict. Go and settle before coming here, which is basically on a weekly basis. I have to settle this kind of issues between patients and bank staff. So I think maybe if we can be able to round up the prices so that it will make it easier for the transaction to be completed. Thank you.
Afternoon once again. I know before this time reconciliation was going on between the pharmacy staff, the collecting officers, and then the cashiers of the hospital. That's reconciliation in 3 places. Initially, when we started, reconciliation continued between the pharmacy staff and the bank staff. But initially, we had issues, especially when the accounting staff of the hospital came in to reconcile, especially at the end of the month. I don't know if there's a clear guidelines as to how that reconciliation could be done without having any infringement, because the accounts, the pharmacy, the agent, I think there's a need for reconciliation so that we arrive at something. Because as it is now, presently I'm struggling with figures, because what the agency has is different from what I have, is different from what the accounting staff have. Because we do like a three-way accounting. You pay to the, the receiving bank. You go and collect a government receipt from the cashiers of the hospital before you come and collect your drugs. So there's a need for that reconciliation. I don't know if there's a clear way where we can achieve that. Thank you.
I will start with the first responders. This project is designed in such a way that all the funds coming, mopping up together, like I said, will constitute 100%. And from the 100%, because it's a revolving fund program, 80% of the money from the 100% will be taken back for drugs, procurement, to strengthen supplies at facility level. Then from the 20% that is remaining, all other expenditures that are project related will be appropriated based on the agreed percentages for the funding of all relevant programs that are included into the project. The budget for DMA will continue to run for other activities that may be a little bit different from running this project. That is what okay, what I'm saying is monies that will be flowing into the system, out of it, 80% will be returning back to the system. The 20% markup will be taken out either on monthly basis or on quarterly basis for the funding of the project activities with respect to all the projects, sub-projects that are attached to these projects. That is the clarification that I have. And I think the steering committee will likely shed more light maybe when I drop the mic. Secondly, on the issue of former programs where we receive a lot. In my presentation, you could see that there is a portion I said is a challenge. Real-time online platform to be deployed by the bank. That system is supposed to manage all the financial components that the bank is posting at the facility level. And it's going to be always reconciling both the financial components and the data elements. That it's been part of the commodities you sell at the facility level. So reconciliation, the system is designed in such a way that technology will carry much of the reconciliation. Still, when we started, most of the facilities I went, I actually informed them to continue keeping their manual records pending when technology will take over the system. In case there is any reason for them to reconcile, those records will bail them out. That is that about that. The second one again is whether the program, price list roundup. The price list, before now, we used to have price lists for the states, but it was not something that was being adhered to at all facilities. This project deems it fits to have a standardized price list that will be for Kaduna State government. And that has been a success story now. We have a price list that, by the design of the project, is supposed to be a monthly price list. This month, we'll bring out the one, in fact, we already shared the one that commodity will be sold for the month of January. The committee responsible for that will continue to be working on the price list based on inflation rates and changes within the framework. If there is any need to review it in February, they are going to review and they are going to bring up another new list for the month of February. Where there is no any inflection rates that will warrant that, probably we may be reviewing them at a quarterly basis. That is that. And for issue of rounding up, it's a point that maybe the state will take decision at the management level or at the steering committee level to see, so that most of the operational problems you are facing at facility level will probably round it to the nearest knots available. So reconciliation was done on between the pharmacies and the bank. So, like we said, because the platform for the technology is still not yet on ground, we'll equally advise all facilities to continue to do your own way, the way you know how to do it best at the facility level, to maintain your records. So that when we come for any manual checkup or whatever as a finance team, you present your record and we see where the issues are coming from. So
it is not appropriate for us to round up monies, because we had discussed about this and we found that it's actually unethical, because in our banks, do they round up your monies? You know, like they just take out money. So who decides when to round up or round down? I don't know. These are questions I'm posing to you. If something is 498 naira, should we sell at 500 or should it be 495? No, I'm asking you. Who should lose? The state should give out 3 naira or the patient should give 2 naira? Who should give out money? Or the state should give out 3 naira? Any other contrary opinion? The patient should give 2 naira. So you see, it's not an easy decision to make. We cannot decide that the state should give out 3 naira, because before you know what's happening, 3 naira is 3 million. And we can't say the patient should be giving out 2 naira, because 2 naira could be 2 million at the end of the month. So the most ethical thing to do is to leave the price as it is. You cost a product, you leave the price as it is, at the discretion of the patient, at the discretion of the bank. It's like you go to filling station and you have change. You have to decide whether to leave it for the filling staff agent, or the filling staff agent might say, take 5 naira, I can, because I've collected 10 naira from deep pocket like Friday, I can give you 2 naira. So you see, it's a financial thing that we can't just sit and decide that let's round up or round down, because the scenarios are multiple. So we just have to cost it the way it is. And that should even get us thinking, how come we're the only country that don't have coins? What's wrong with us? How come we're the only country that don't have coins? What is wrong with us? All the countries we are trying to emulate in the whole world have coins. Why is it that we're the only country that don't have coins? So that's why I say this transformation is throwing up a lot of challenges. And this is a question we should be asking ourselves. Every country has coins, but we decided that we are not going to use our coins. We want to collect, or we want somebody else to give. So that's not our forum. They will keep fighting. That's just the truth. Until the CBN governor settles them. Okay. And then there's the issue of, okay, the markup. Okay. So I'll just say what he said again. The selling price list, the unified selling price list that we share to facilities, has a price on each product. That price that you see is cost price plus markup. This thing we're explaining is nothing new. That was the old system. That was something that we carried over from the old system. The markup on product is supposed to be 20%. Am I right or wrong? So it's nothing new. You buy product and then you add markup of 20%, and that makes the cost price now becomes the 80%, and then the markup is 20%. So when a patient pays for that product, the 80% must go back for replenishment. of that product. You have to buy it again. Then the 20% is spread up for all the activities in the supply chain. Is that confusing? No, it's nothing new. It's the only thing that is new now is that when we're in the pilot, we had people paying for almost all the things, a lot of things that we're seeing, like third-party logistic, PSA, BMGF was paying for it. We have the SMS, even the SMS platform, we procured it ourselves, it's not free. The control tower, BMGF, PSA is paying for it, but when they leave, we have to continue to pay for that product, the services that we're enjoying. So that is why we're thinking of it right now. We will not wait until the day they are leaving, then we'll start scratching our head like, where are we going to get money to pay for license for control tower? Where are we going to get money to pay for third-party logistics that everybody loves? So every activity of the supply chain will be paid from that 20%. And even the incentive is in that 20%.
Hello.
So any other questions?
So we'll now take the next presentations. The other presentations will be very fast because we are running behind time. So we're taking from Human Resources. It will be taken by Farm Daniel.
Despite the public service reform in Kaduna State and the restructuring, the good governor of Kaduna State have allowed for the recruitment of health workers in the month of October. One of the activities conducted again is the capacity building of facility health operators for this program that we are running. 20 consultants were recruited, 50 medical officers, 1,000 nurses, 25 pharmacists, 50 pharmacy technicians, 10 lab scientists, and so on. And out of that recruitment, 8 pharmacists from 25, 8 pharmacists were posted to 4 pilot secondary healthcare facilities. We have 5 healthcare facilities, but to some extent, I think Baroduko are like independent, so that is why they are not included here. And out of the 70 medical doctors that were recruited, 34 were posted to our 4 pilot secondary healthcare facilities, 12 to Kafanchan, 9 to Yusuf Dansoho, 7 to Gambo Sawaba, and 6 to Dr. Gomna Awan. 14 pharmacy technicians also posted to pilot facilities. There have been capacity building. That's one of our achievements. It was carried out to enhance the performance of our operators. Our challenges are like this. Competency issues, capacity gap is one of our challenges. Also, we have competing priority of programs for health facility staff. I was asking some of my facility operators that are supposed to be here, I was asking her, where is your second? The pharmacy technician that is in charge of drugs. And I was told that she had to attend to one other training by one organization. And I think at the end of the day, is it a volunteer that has to be in the facility because she has to be here also. There have been transfer of some staff, mainly in the PHCs, to other facilities that are not running the program. And also one of the challenges, which I believe it has been, is being addressed, and I think the assurance we have very soon it will be resolved, is that there have been small delay in payment of salaries for PHC health workers. Is it big delay? Adashedeko? All right. So, some of the lessons learned. Effective mobilization system for health facility staff based on performance is really key to the success of the project. There is this exception-based monitoring and supervision. That's monitoring based on report that has been generated. This facility has this issue, so you go and check them and resolve that issue. We discover that it helps in project performance. Facility operators now have more time in their facilities since their products are being brought to the facility by the 3PL. Before now, they will be spending their time coming down to the DMA. Somebody from Sanga, it may take 1 or 2 days before coming to the DMA itself, putting up requisition while the facility is empty. We discover that the facility operators now have more time with their patient. Thank you very much.
Standard. We also realized that there was also need for the training of staffs, where we understand that the basic skill sets required in carrying out such activities, it's actually deficient in most of us. So there was that need, and there was proper organization of such trainings by IHS and also some of our partners in that. And we also realized that apart from also formulation of such SOPs, there was also need in carrying out on-the-job training, so that each operational staff would be familiarized himself with such processes in order to carry out his activities. And also the use of third-party logistics, which for me personally, and I will also believe that some of the facilities head here will also agree with me that it has been very effective in usually for a facility like, let's say, Barodico, sending a requisition of, let's say, 6 million naira can take us almost close to 2 or 3 days in picking such commodities. But now with proper arrangements and also pellet labeling in our warehouse, the picking time has greatly increased, which we can do within a space of 2 to 3 hours when we have the required manpower all on ground using that. And also carrying out the assessment of our warehouse, we were able to come up with the costed kappa, which is corrective and preventive action or assessment of our warehouse. And we found out that for us to upgrade our warehouse to a farmer grade standard, we'll be requiring 11.5 billion naira from the government to support that. And we're also able to improve our storage capacity, most especially for the thermolabile commodities. In the past, what we had to do was to either purchase less or whatsoever it is that we have. We now have to liaise with primary healthcare agency to provide us space for that. But now we've been able to do that. And also we've been able to accommodate the omni-channel of requisition. What do I mean by that? Most of you agree with me that for hard-to-reach facilities like ESC, you don't have to send me a mail. Some of them will even tell you that I don't have a mail. You can send via SMS. I know facilities like Haji Agambo Sahaba that he prefers to even call you on phone. So it's either you send via phone, call, whether SMS, or even our WhatsApp platform. And this, we're able to achieve that. And also looking at our achievements in terms of warehousing and also product availability. Here we could see that initially when we start, we were able to have about 340 SKUs, that's product SKUs. What do I mean by that? Let's say we have paracetamol tablets by 1,000, irrespective of the brand. And this, we understand that these things are coming from facilities requesting, I need this particular brand, I need this unit pack. But in the course of the program and also the pilot study, we were able to improve on that, now presently having 433 product SKUs valued over 139 million naira. We can go to the next slide. Also, which for me personally, I believe that this is one of the major improvements in terms of processing time for requisition. You all agree with me that initially, you have to write a written requisition, send it to DMA, DMA now will now have to prepare a picking list and will now have to call you and say, this is what we're able to prepare for you. When are you ready to pay? You say, okay, I'm going back to my facility. I have to now speak to the CMD to raise a voucher and say, okay, we are ready to pay now. Most of the times, you have to now call us back and say, okay, based on the picking list, it was 70,000. But now we're only able to source for 50,000. Please, can you reduce this? All those things were taking time. And it will take another time to mobilize funds in coming down to DMA to pick those commodities. And we realized that over the course of the study and also using the baseline assessment that was carried out initially, that it takes an average of 36 days for PHCs, that's the primary healthcare centers, in processing their orders. While now at present, with the different omni-channels of communication and also improved financial system, we've been able to achieve that within less than a day. We can go for the secondary health facilities also. Okay, for the secondary health facilities, it's not different from that. Using the baseline assessment, we could see that it was also an average of 36 days. But we could see an improvement here. Starting from the first quarter, went down to about 13 days. Now in the fourth quarter, we could see having an average lead time of 7.8 days. That's, let's say, averagely 8 days. But I want us to also understand that we are not only managing 28 facilities. We have other facilities that are not captured under this system. So what do I mean by that? That when you send in your requisition, you are not the only one sending. We have others too coming. So we have to be able to service them and also at the same time service you. And you also agree with me that there have been an improvement in that. Okay. And also in terms of requisitions sent and how many you were able to service over the course of the study, we could see that for primary healthcare facilities, we were able to service over or about 100 requisitions valued at about 10.2 million naira. And also, let's go for the secondary health facilities, 73 requisitions valued over 122 million. That's over the course of the study. We can go to the next. Okay. In terms of distribution and also costs in distributing these commodities, using the baseline analysis carried out initially, we found out that the cost of transporting 1,000 watts of commodities to facilities, to the PACs, will cost you an average of about 301,000 naira, or let's say about 300,000 naira. This is putting into consideration the storage costs, the management costs, the transportation. Facilities coming from Guantu will now have to pay for accommodation, which of course you know that the processing time was usually long. You have to get a place to sleep and all of that and this. But in the course of this study, using the third-party logistics, we've come to find out that it has been very effective at spending an average cost of 310 naira just in transporting commodities from one point to the other. And you are able to get that on time. You are able to get that on time and to be able to verify whatsoever the case is. And you also agree with me that most of the times for these local government or for the PACs, they usually don't come down to DME themselves to procure. It has to pass through the local government stores. That's another extra cost. Bringing it down, putting it in their warehouse, then PACs now coming, making requisitions. All those things are part of the cost and also time consuming, which we've been able to improve over the course of time. Okay. And also for the secondary health facilities, it's definitely not different from what we've been saying. 5,000 times the cost of servicing and also distribution over the course of time, where here we can even see that it will cost you an average of 35 naira in distributing or in conveying such commodities. We can go to the next one. Our challenges. Inadequate electricity or power supply. I think it's not just common to us, it's a national issue, which you all agree with me. The reason why this is a challenge, as I've stated earlier, that we have thermolabile commodities like the vaccines and also the anti-snake, TT and whatsoever. In terms of warehousing, inventory or management system tools, it's important. We found out that especially like the M-Supply software, most of us are actually not conversant with that. So in that case, we have been underutilizing it. So there's a need for capacity building and also further training in order to be able to maximize that. Also, in the case of warehousing tools, which was also captured under the costed kappa, we realized that there was also a need in the provision of racks, in handheld jacks, so as to improve even the processing time, the picking time, and likewise even the delivery time, which we also understood. Also, in the case of, initially we had delay payments of requisition, which which later on increased the order processing time. That was on the initial onset, but now with the present system, having a centralized accounting system, it's much more faster. And also the issue of poor phone network, or will I say connectivity. A typical example is PSC Kono. Is PSC Kono here? All right, you're welcome, man. Yeah, okay. PSC Kono, we normally have that issue with PSC Kono. Whenever they are going to send requisition, they have to be out from Kono. And they need to find themselves in my local government. Where? Samunaka. It's either they find themselves in Samunaka or the nearest local government, Kauru, in order for us to be able to get them to send in their requisition or even to help them in processing those requisitions. And likewise with even the third-party logistics. What he normally says is that when he gets to Kono, he needs to get to the office of the district head also, or the village head, so as to make appropriate contact for them to get whoever it is that is in the facility. This is actually a challenge. Okay. And also insufficient inventory in the DMA. This, of course, is true. Most of you agree with me, and I've seen questions coming out asking that, why are we not having what we requested for? And most of the times, I'll tell you that right now we are processing or we are procuring and this and this. Whatsoever it is that you are seeing in your invoice, right now, this is what we have, but we are making provisions for that. In the next possible time, we are going to supply you that, which we've been able to do over the period of time. And also making requisitions using brand names. A typical example that we were sharing yesterday was the blood tonic Buntu facility. Savantasha, okay, let me call the name. Savantasha yesterday sent a requisition saying we need Buntu. Then the person processing the requisition, Mallam Musa, said, "What is this?" I said, "It's a blood tonic." He said, and most of us don't actually get to know, or some of the people don't get to know. So you now have a challenge of what does it mean? And likewise, you also agree with me that you have that challenge in now sending in your consumption data. When you don't know the generic name of that particular commodity, it's usually hard for you to locate it in the pricing list or in the selling price list, which is usually a challenge. And also the handwritten, you write Ubuntu, or you can even decide to say, I need paracetamol 20 or 60. For me, snapping it and sending it through WhatsApp, I think it's 80 or 60. That is why we also have that challenge that someone raised the question saying, we requested for 10, and you now sent 10 cartons. This is also tied to the unit of measure, which I will also want to explain here. I remember you called me personally, and I said, okay, 10, what do you mean by 10? Is it 10 pieces or 10 cartons? And for the person processing that order, we'll just feel like, okay, this is 10 cartons. And we'll now look at your sales and say, okay, this person can actually afford that. Looking at, after making your picking list and saying that, well, it's just 40,000. When we top this one up, it's just 100,000, and we know that these people are selling. We'll now send to you, only for you to later on now call and say that is not what you require. Another typical example was we sent amylorite hydrochlorothiazide. You now wrote moduratic. We now sent to you. When the third-party logistics got to the facility, he saw that the person receiving that commodity wasn't in charge, it was the second person there. He now said, no, this is not what we requested for. He said, okay, what was it that you requested for? We requested for moduratic. Okay, but we are seeing here in the invoice that it's amylorite hydrochlorothiazide. It is the same thing. It's just that you don't know the generic name. And those ones are actually issues, you understand, that arise in even processing orders. And most of the times I have to now begin to call facilities to ask you, is this really what you need? You understand? But I believe that in the long run, we get used to or conversant with those pricing lists and likewise the generic names, which will in the long run. And also completing the reef. You also agree with me that facilities initially were meant to fill in the reef. That's the receipt and reissue and voucher, where when you come to DMAs, after processing your order and everything, you have to now start following those commodities, writing them one after the other. A typical example, Baraudico can now send a list. After making your invoice, you're having a list of 150 commodities. You now have to start writing it one after the other. We sat down and discussed about that, and the staff officer said this is part of their auditing process, and whenever auditors come, that is one of the major things they have to verify. So we had to continue with that. And that is also an issue because right now facilities are being spared with that problem. The store officers are the one now having to sit down, write down that one down. So that on its own will even increase the processing time for you to get your commodity service to your facility. I also want to tie that one also with occasional late night delivery. When I have 150 commodities that I needed to write them down, after clearing, after doing the pick and pack, checking with the third-party logistics, I can't just come to your facility and just deliver to you without you seeing that reef report, because that will be the first thing that you ask for. And if you are not able to fill it, how do you expect us to now deliver those commodities to you? That is one. Two, another challenge also tied to this is most of the times it's like we don't really get to know when your commodities is running out. A facility will now just call me, a typical example, two, in fact, even one will just call me today that, sir, my prescription booklet is getting finished today. Please supply me. How is that possible? You understand? And it's also common with commodities. You are running out. At least if you have a foresight of saying, okay, it can take me 1 week, start making that requisition. In order to meet up to that demand, a typical example also I can give. Let's say Sir Patrick sent a requisition on Tuesday, or let's say on Wednesday. I was able to process that. In the course of processing it, then now I'll say, okay, let me deliver the next day. Manchok, PSC Manchok will now send another requisition, will send a requisition. I'm still trying to process that one. Mallam Kajuru will now send another requisition. Before you know it, it's now taking 3 days or 2 days. Then Sir Patrick will now call me and say, sir, we are still waiting for our commodities. And in my mind, I am trying to see how I'll be able to harmonize the 3 requisitions and service them before Friday. Why? Because I know that facilities operate 24 hours. And I know that there might be stock out either Saturday or Sunday. So in my own thinking, I'll say, okay, why not let's now join these 3 requisitions together, knowing fully well that they are all going through the same route. Mallam Kajuru, Manchok, Sir Patrick. Before it gets to Sir Patrick, it might be 9 p.m. Which one is better? To service you at night and not be stocked out during the week, or to service you on Monday when you're already stocked out? We understand. But that on its own, we understand that is a challenge. Why? Because we still don't have our consumption data on hand to be able to make that informed decision. For the lesson learned, one of the fundamental issues here that I personally and facilities, I believe, will also agree with you, was the timely delivery using the third-party logistics, where you don't have to stress yourself saying, I want to come down to Kaduna to procure. And of course, a lot of you will now tell you that I don't like coming to DMA. Whenever you come to DMA, you have to spend the whole day. I have friends that are in facilities, and of course, they know. They will tell you that no, DMA is a no-go area. There will be delay, you have to be moving from one office to the other. Where is chief store? We are looking for the chief store to give us the final clearance. Before you know, chief store is there attending to something else. This is actually improved that using the third-party logistics in making it easy for us to process our orders and also on time to facilities. And I also came to also understand that on-the-job training and also continuous capacity training for operational staff, it's important and very effective in increasing the processing time and also the picking rate, and also likewise the arrangement of the arrangement of our commodities in the warehouse. Thank you very much for listening.
How far have you gone in assessing the warehouses of all the facilities? Because it's not only you, the parent caregiver, having a standard facility. What about facilities like in the primary health care, my facility, let's say Barodico? How far are you sure I'm having a good warehouse to protect the drugs and make sure the quality of the drugs that stay in my facility is good up to the time of delivery to the patient? Thank you.
You agree with me that this is a project in progress and it involves several processes. It's just like you learning how to run. First, you need to learn how to crawl, then walk before you're able to run and all that. And one of the first things that we're able to do, as I've stated earlier, was to assess for the warehouse where that is the major challenge. First, you need to get those drugs stocked and also available for facility. But still having said that, we will definitely be coming down to the facility level in assessing that, and also to ensure that we put all those processes in place, and also to also develop your own warehouse. It's something that will be done eventually. Thank you.
All right, thank you very much, Warehousing, for your presentation.
Just to add to that question that you asked, I think it's very important that we all note that our pits are intertwined. There's no difference between the DME and the facility as long as the patient has not gotten his product. So whatever we have at DME, for this project, we believe that the facilities should also have. And we have been discussing this. You've mentioned the warehouse or your storage spaces. They are supposed to be pharma grade, just like the DMAs, if we get the 11.5 billion. And then we'll come down to the facilities. We've also talked about capacity building. We have gaps at DMA, and I know there are gaps at the facilities. So all the challenges, that's why the supply chain is one. Whatever challenges you have at the facilities, we have them at DMA, and we intend to, as we go forward, address all the challenges, starting from the main warehouse, then we'll go down to the facilities. Just so that you know, it covers everything, all your challenges. Thank you.